one of the homework questions that I asked you all to research a little bit is how do you measure intracranial pressure? How do you measure the pressure inside the brain? So, interesting and difficult problem because the only real way to do it is to actually stick a needle into the ventricle. But obviously you can't do that in most circumstances because of the risk that's involved. So there are some kind of unique other ways that we've come up with to actually measure the intracranial pressure. One other way that we can indirectly assess intracranial pressure, because the intracranial pressure should be less than 10 centimeters of water. The one way that we can kind of indirectly measure that is actually just to look in the eye. Because when the intracranial pressure goes up, that pressure is transmitted through the dura into the back of the eye and produces a problem in the eye which is called papilledema. Papilledema. So you'll probably see that again. Papilledema just means swelling of the optic nerve here. And so I can indirectly, I can't quantify it, but I can look into somebody's eye and I can tell if the intracranial pressure is grossly elevated just by looking for papilledema of the optic nerve. And so one of the things that can raise the intracranial pressure is meningitis. Have y'all, I imagine all of y'all been vaccinated for the meningitis, right?
Yeah.
Yeah, so it's an endemic problem, particularly when you get a lot of people that are kind of living close together. It can produce a non-obstructive hydrocephalus. Meningitis is characterized by headache, usually pretty high fever, and a stiff neck. Those are the characteristics of meningitis. So headache, usually a fairly high fever, and a stiff neck. In fact, somebody has meningitis, you know, if you try to move their neck or you try to move their head, they will actually kind of act like a stiff board. And that's kind of the way that it tells you that there's a problem with meningitis. So meningitis can produce terrible problems. One of the things that meningitis produces is deafness. So young kids that get meningitis oftentimes become deaf. And that's actually one of the largest populations that we currently have for implantation of some of the auditory prostheses, the cochlear prostheses. This presents a serious problem, obviously, quickly. Early diagnosis, early treatment, usually can resolve the problem. Now, the second thing that we're going to talk about in terms of circulation is actually the blood circulation for the brain. Now, as we mentioned, last time, the brain is only 2% of the body weight, but it gets 20% of the blood flow. So obviously the brain is prioritized in terms of getting a lot of blood flow. Now there's only 4 ways that blood can get into the intracranial space. There are 2 vertebral arteries and 2 internal carotid arteries. And so these are pretty much mirrored right and left. There's a little difference in the way that they take off of the aortic arch and the subclavian, but basically, you can kind of follow. I'm going to kind of trace this out. So you have the subclavian artery here, and then you have the internal carotid artery here, and then this divides. So that you can see this. So anyway, the internal carotid divides right up underneath your chin into the internal and external carotid. The external carotid goes to the muscles of your head. And the internal carotid is what nourishes the brain. So you can kind of see that kind of go there. So here's the internal carotid, comes through the carotid canal, and then it does something very unique. It's the only place in your body where an artery actually passes through a vein. So the internal carotid, as it turns and makes what's called the siphon of the internal carotid, it passes through the cavernous sinus. And it's, I don't know why it does this, but this is the way it works. And then it goes forward a little bit, and then it turns backwards. And then it goes and ultimately it divides into the middle and anterior cerebral artery. But
that is one of the ways. Now you've got, it's only showing the on one side, but you understand that it's pretty much the same on both sides. Now one of the key things that I wanted to point out to you in this diagram, which you need to make a note, is the very first division, the very first blood vessel that comes off of the internal carotid is this one right here, which is called the ophthalmic artery. And so the significance of that is that if you have a embolus, if you have a blood clot that develops at the bifurcation of the internal and external carotid, the very, very first place that it can go to is the eye. It doesn't go to the brain first, it goes to the eye first. And that's because the ophthalmic artery is the first division, intracranial bifurcation of the internal carotid artery. Okay? And so this produces a constellation of symptoms, one of which I expect y'all to understand, and this is called amaurosis. So amaurosis is a syndrome where you transiently lose vision in one eye. And so typically somebody who has an embolic kind of a situation, they will complain of transient loss of vision in one eye. And so they'll come in and present to you with a symptom of, Doc, I was driving down Mopac today, and for 3 minutes, the vision in my right eye just completely went out. But then it came right back. Okay, and so the next question is, should I be worried about this? Okay, and so the answer is definitely you should be worried about it, because the next time it happens, the blood clot might not go to the eye, but it might go to the brain. Okay, and so this is a harbinger of stroke. It is a way that people get warned that they're about to have a stroke. So transient loss of vision, we call it amaurosis visax. It's basically a visual phenomenon, loss of vision, transient loss of vision for just a few minutes in one eye that almost always completely recovers. Yes?
So what dictates whether the blood clot goes to the brain or to the eye?
So, it's a crapshoot. It's a probability. And so it just so happens that the ophthalmic artery is the first branch. And so it almost always gets a little clot or a little symptom before it actually gets a big clot which goes into the trigone of the middle cerebral artery. But it's not always. I mean, people a lot of times will have a stroke and won't have this. But if they have this symptoms, if they have this constellation, if they have amaurosis, they're at very high risk of having a stroke. And almost always this is caused by a arteriosclerotic plaque, an embolus, which occurs right here where the common carotid divides into the internal and external carotid. This is a place where there's a lot of turbulence. And so anytime you get turbulence, you get endothelial defects in the blood vessels. And when you get endothelial defects, it's very easy to get an atherosclerotic plaque. And then a piece of that just chunks off, creates an embolus, which then goes and produces a stroke. Okay, so somebody that has this kind of symptom, what we do routinely is just to send them over for a carotid Doppler, because it's a very non-invasive blood flow test where you can find out what the blood flow is in the common and external, internal and external carotid and common carotid, and you can tell if there's any obstruction. If there is obstruction, then you have to have an angiogram. And if the angiogram shows high-grade occlusion, then the surgeons, the vascular surgeons, will go in, typically from the femoral artery, and do what's called a carotid endarterectomy. Carotid endarterectomy is a kind of a plumbing job. It cleans out the plaque, and that decreases the risk of a stroke. Okay. Now, there's one other interesting syndrome that you need to learn for this class, and that is because the artery goes through a vein right here. So This is a busy, busy place right here. So here we have the carotid artery going through the cavernous sinus. One of the other things that can happen is you can actually rupture the artery inside that vein, inside the cavernous sinus. And if you do that, then you end up with what's called a carotid cavernous sinus fistula. And this happens not infrequently with head trauma. So you have a bump on your head, you get tackled when you're playing football, or you head the ball when you're playing soccer. You don't think much about it until a day or two later you start having a very, very red eye. Eventually the eye becomes proptotic. It begins to kind of push out. And it has a very characteristic auscultatory sound to it. So if you take your stethoscope and you just put the stethoscope on the eye, you hear a swish, 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 swish. You hear a pulsing, which you should never hear. If you put a stethoscope on your eye, you should hear nothing. But with the carotid cavernous sinus, you can actually hear the blood flow that's being transmitted from the carotid into the orbital veins, which is causing the eye to become proptotic, and it's causing all the blood vessels in the eye to become very arterialized. So basically they're all becoming like these big, dilated, tortuous arteries, and it produces a very, very red eye. And so not all red eyes are pink eye. This is a kind of an interesting syndrome. It's called a carotid cavernous sinus fistula, and it's the result of a tear in the carotid inside the cavernous sinus. Now, let me kind of go over the important things that you need to know for this class in terms of the circulation. And so I'm going to kind of draw on here the way that the blood can get into the head. And so we have two vertebral arteries, 1, 2, okay? And these two vertebral arteries join up and make the basilar artery. Basilar artery is right anterior to the brainstem. This then comes forward, and you divide off into the posterior cerebrals. These are the posterior cerebral arteries. Okay, but there's another little artery right here, which is called the posterior communicating artery, which comes up into the other ways that blood can come in through the carotid. So these are the two carotids. And then the carotid then divides into the middle cerebral artery and anterior cerebral artery on each side. And then right here is another artery called the anterior communicating. So if you look at that all together, it makes a circle. It's called the circle of Willis. And so the blood flow in your head is so important that you have redundancy where you can perfuse the whole head if you only have 1 out of the 4 blood vessels that works. So that's kind of incredibly, phenomenally redundant. So you can actually cut off the circulation. There's 4 big blood vessels that are coming in, the 2 vertebrals and the 2 carotids. You can tie off 3 of the 4, and because they're all connected in this circle of Willis, because they're all connected, you can perfuse the whole brain with just 1 blood vessel working. Okay? So here's another way to kind of look at it here. Here's the vertebral, posterior cerebral, posterior communicating, joins the internal carotid, and that divides into the middle and anterior cerebral. Here's the anterior communicating. And so that makes a circle. I'll draw the circle here, which is called the circle of Willis right there. So that's kind of cool. It's redundant. It allows the brain to survive all kinds of terrible vascular injuries. Now, in all fairness, that's kind of a diagram, but yes.
So does that mean, like with strokes and with those kind of ailments, that it has to happen lower down and not in that kind of area?
Right. So what it means is if you have some injury that affects your neck or it affects the bigger blood vessels as they're coming in, then you're not going to manifest a stroke. You're going to do okay. Okay. It doesn't say anything about downstream from the circle of Willis, but in terms of the input into the kind of this redundant system, you only have to have one blood vessel that works. 1 out of 4. Yes?
If one of them were to rupture, would that cause a stroke?
Well, we're going to talk about that in a minute. That's a whole different story, okay? That's called a hemorrhagic stroke, and we're going to get to that in just a minute. So I'm going to defer your question. Okay, so again, anatomically correct here. Let me draw this out again here. There's the two vertebrals, the basilar, posterior cerebral, posterior communicating, internal carotid, anterior cerebral, middle cerebral, anterior communicating, and this produces this circle right here called the circle of Willis. It's also interesting that this is real close to the hypothalamus, the optic chiasm, and the mesencephalon. So it turns out that this is actually an incredibly busy part of your brain and brain stem. So it's not uncommon to get, for example, an aneurysm. So another bad thing that can happen here is because the communicating arteries are smaller than the bigger arteries, they don't have as much muscle. What happens is you can get an aneurysm. Okay, so here's an aneurysm that pops out of this little vessel here. So that aneurysm is going to press on the brainstem, and it can kill you very quickly. So aneurysms are very, very dangerous. One of the other things that happens, so if you look back here at the posterior communicating, here's the posterior communicating. One of the very first places that it goes and can knock off is the third cranial nerve. So an aneurysm is going to give symptoms because it's in the midline structure. It's going to give you symptoms of oculomotor palsies. So you'll understand what those symptoms are in just a few minutes. But basically, you've got all this busy structure right here that involves the optic chiasm, the hypothalamus. So this is going to be the hypothalamus here, chiasms here, the mammillary bodies are down here, and so aneurysms are going to clip the cranial nerves, and they're going to give you some very significant, life-threatening symptomatology very quickly. Y'all ever known somebody had an aneurysm? Yeah.
Well, I did, but is there any you get a warning?
Well, tell us what the story is.
I mean, I didn't know. One of my friends knew their mom or something that happened.
And what happened?
It was unfortunate after that, but yeah, do you get an immediate sign or?
Well, what happened to the patient?
I don't think she made it after that.
Right, it doesn't really. Most people don't make it.
Yeah, but do you get a sign or is it just you're gone?
Yeah, you're here one day, gone the next.
Well, is it?
What are the symptoms? What are the symptoms? Headache. Anybody here ever had a headache?
There's no warning. It's just.
Yeah, not much. Usually not. So the symptoms of a bleed. So if you have an aneurysm, first thing you're going to do is you're going to get some of these, what we call them midline symptoms. So if it hits the third cranial nerve, you're going to get a dilated pupil, and you're going to get an extraocular muscle palsy. So that's one symptom. So we pay, as ophthalmologists, we pay great attention to pupils. If you have anisocoria, if you have a difference in the size of your two pupils, that is very bad. That indicates that something's going on here, and it could be an aneurysm pressing on the third cranial nerve. The other thing that you have to watch out for is an increasing headache, increased level of just basically you get a tundy. And if you have rapid progression, then you absolutely got to go to the emergency room quickly. It is fixable. It's 100% fixable. A neurosurgeon who knows that there's an aneurysm, so basically somebody comes in, we do an angiogram. You can go in and put a little clip on the neck of the aneurysm, and the aneurysm goes away, and the person's absolutely normal. But you have to do it quickly. If you wait and the aneurysm bleeds, the bleed produces a space-occupying lesion, and that compresses the brainstem and you die. Okay? Now, there's some other little things that you need to know about, too. There are some other blood vessels that are important for you to understand and know, and that are the lenticulostriate arteries. These are the arteries that are located right here. So if you look at the older part of the diencephalon of the brain, The lenticulostriate arteries provide the blood supply for those nuclei. And so the lenticulostriate are providing blood to the caudate, putamen, and globus pallidus, and part of the thalamus. And so these blood vessels are very, very thin. They're very thin walled. They're coming off of a very big blood vessel, the middle cerebral artery. So this artery right here is the middle cerebral artery. Okay? And then these little tiny blood vessels here are very much prone to bleed. And so if you have increased blood pressure, okay, not uncommonly, you get bleed, which occurs in the basal ganglia part of the diencephalon. And so that's another way, and we're going to come back and address that in just a minute. But just remember that these lenticulostriate arteries are the ones that are prone to bleed because they're very small diameter and they have very thin walls. Okay? Any questions about the circle of Willis before we kind of move on? Okay. So eventually we end up with basically three big circulations that come out to the cerebral surface. Now you have to remember that in your brain, all the cells are on the outside. So all of the cells of the cerebral cortex are in the first, 4 or 5 millimeters of the cerebral cortex. They're the energy-intensive, oxygen-consuming, part of your brain. And so your circulation, your blood flow, is mostly on the surface. And these blood vessels are on the surface of your cortex. When you open the skull, you will see these blood vessels. Okay? And so we have three circulations. We have a middle, kind of a middle circulation, which is shown in the red here. This red is basically the circulation of the middle cerebral artery. We have an anterior cerebral circulation, which provides the blood flow to the kind of the medial aspect of the cortex. And then we finally have a posterior circulation, this one right here, which provides the blood flow for the inferior portion of the temporal lobe and for the occipital cortex. And so you can kind of imagine that this artery, if you knock it off, you're basically going to end up with a stroke or something that affects this part of the brain. So it turns out that the posterior circulation is very important in terms of visual symptoms. And so we see people that have a posterior cerebral infarction, they're going to have a hemifield loss. They're going to have a loss of part of their vision, half of their vision. Okay. If somebody has a middle cerebral stroke, something that affects this part of your brain, it's going to affect your motor strip. It's going to, so basically this is part of the brain that controls your motor function on the opposite side of your body. So a stroke, for example, in the right cortex is going to give you weakness on the left side of your body. It's also going to affect the postcentral gyrus because it's the same circulation. And you're going to end up with paresthesia, so you're going to end up in anesthesia. So you're going to end up with numbness, tingling, and loss of motor function on the opposite side of your body if you have a middle cerebral artery stroke. Anterior cerebral artery, because it affects the medial aspect of the cortex, is going to give you cognitive defects. It's going to cause you to have changes in your affect. And so based upon the territory that's involved, the symptomatology is going to be greatly different. In fact, you can differentiate which circulation just by taking a history when the patient comes in with a stroke. You can tell whether, real quick, you can tell whether it's middle cerebral, posterior cerebral, or anterior cerebral defect. Okay? Now, to get to the question that was asked earlier, there are two different kinds of stroke. One kind of a stroke is a bleed, for example, from an aneurysm. And so what we have here is an aneurysm, which is bled and has produced a space-occupying lesion, which has caused a midline shift in the brain and compression of the brainstem. So an aneurysm causes an intracranial bleed. You can get an intracerebral bleed. You can get a bleed from those lenticulostriate arteries, and that usually occurs in the basal ganglia. And that then produces, again, a space-occupying lesion which will produce a midline shift. Remember, the brain is like jello, so it moves over, and when it moves over, it compresses the brain stem and you die. So this is called a hemorrhagic kind of stroke, hemorrhagic stroke, as opposed to the ischemic stroke. An ischemic stroke is where you have a blood clot. Here, for example, is a blood clot in the middle cerebral artery, and you knock out a part of the anterior, basically it's the anterior lobe, motor strip, and you have symptoms of what we usually see. This is the more common ischemic stroke. The story here is a 75-year-old man or woman suddenly presents with numbness and tingling in their arm and leg, and they typically might have slurred speech. And so, when you have those kinds of symptoms, then you would suspect a stroke, and the thing to do is call 911, go to the hospital, and you get diagnostic services, and then there are ways that you can treat these things. Anybody here known somebody who had a stroke? They're very common. I'm sure people have known people who had a stroke. Yeah, question.
I just had a question. Is one stroke more like dangerous than the other, or more fixable?
Yeah, in terms of pathology, the hemorrhagic stroke is more morbid. So your fatality rate, the morbidity from a hemorrhagic stroke is higher than an ischemic stroke. So what happens if you have symptoms? You have numbness, tingling in your arm or leg, slurred speech. Well, if you go to the emergency room within the first 6 hours, you can receive a drug called TPA, which is tissue plasminogen activator. So for this type of stroke, if we timely give TPA, we can dissolve the clot and restore the circulation. Have y'all studied in your other classes the clotting sequence? Y'all know about thrombin and plasminogen, those things? Yeah.
Is it only if you do it soon enough, because if you don't, the brain tissue dies in that area?
Yeah, the brain, so this, the brain tissue only has 3 minutes, without blood flow. Now what happens is real interesting. So even though you've knocked off that blood vessel that goes to that particular area, there's what's called a watershed circulation. And so that part of your brain will steal a little bit of the nutrients in the circulation from the other blood vessels that are kind of close. And so you've got a little bit more leeway as opposed to totally stopping the circulation. So if you totally, if your heart quits beating, your whole brain, there's no way you get watershed because all the blood vessels are perfused now at 0. And so with a localized embolus, you have a little bit more of a grace period, to treat that. Okay? Yeah.
How would you treat a hemorrhagic stroke?
Good question. Let's not get there quite yet. How do you diagnose? I'm going to ask you this question. So a patient comes in. The symptoms are going to be the same. I'll tell you, the symptoms are going to be exactly the same. Numbness and tingling, your arms, legs, slurred speech. Okay? How do you diagnose? And why is it important to diagnose whether it's ischemic or hemorrhagic? Why is it important to make the right diagnosis?
They're required for treatment.
They do, as a matter of fact. Okay? Why? If you give somebody that has a hemorrhagic stroke, TPA, what happens? It increases the hemorrhage, right? So you die real quick. So, as the emergency room physician, what are you going to do? You're the doc. Patient's got stroke symptoms. You know that. You've already figured that out. What's the diagnostic test you're going to order?
Could you ask them their medical history or look at the
Well, that would be a good thing. So they usually come in with a family member. You ask them, well, have you had hypertension? If they've had hypertension, then it's more likely hemorrhagic. Okay, but it doesn't tell you for sure. But that is good. History's a good thing. You always want to take a history. It's kind of interesting, but most patients, if you ask, if you just listen, if you listen, they'll tell you what's wrong. Okay, we're not very good listeners. Okay, You ever been to the doctor sometimes and the doctor's so busy, you think you're just another piece of number or something. They don't listen, right? Okay. But a good doctor will stop and listen, because 90% of the time the patient will tell you what's wrong with them if you just listen. So that's your idea of asking the history is a very good idea. Okay. But what else are you going to do? It's a critical decision. Do what?
Can you listen with the stethoscope in here?
Yeah, well, you can listen with stethoscope, but they probably don't have a carotid cavernous fistula. Yeah.
If you like stick a needle.
No, let's not stick in the needles.
Check the intracranial pressure.
Yeah, well, so you got to be a little bit careful. So you start sticking needles in people. One of the things that you have to worry about is if you stick the needle in the wrong place, you can cause the hemorrhage to get bigger. Okay, so you got to be a little careful about that. Plus, if you stick the needle and you do it, for example, in LP, I think where you're going is just doing lumbar puncture and look for blood. Okay, yeah, you can do that. So if you have a hemorrhage, if you do an LP, you're going to probably see red blood cells. You shouldn't see any red blood cells, right? So you do an LP. But the problem with that is if you have a clot up here in the brain and you do an LP down in the below L2, what happens is you now all of a sudden have decreased intracranial pressure and you'll kill the patient instantly. Okay, because now you have nothing pushing the brain back, so the whole brain's going to herniate down through the foramen magnum. You get the whole brain just pushed down. You instantly kill the patient. So that's actually not something you would probably want to do. Yeah.
Do you have a headache when you have a stroke?
Yes.
Can you ask them where exactly their head hurts? Will that help?
Well, that can be helpful. Yeah, and actually, these patients are going to have localizing, we call them localizing signs, so you can tell which side it is a lot of times by what the symptoms. So you know that if they've got numbness and tingling, on the right side, right arm, right leg, numbness, tingling, they're weak on that side, it's probably something's going on in the left part of your brain. Okay? So you already know that. You got that information. Yeah.
If you do a CAT scan,
Yeah, that's what I'm fishing for. You got to image them. So any hospital that takes stroke patients is going to have some access to imaging, and so this will show up a hemorrhage will show up very quickly on a CT scan, just within a few minutes of time the patient hits the door, emergency room with symptom of stroke. You get a CT scan, and it'll show whether or not there's a bleed. Now, it really won't show if there's an ischemic. A lot of times it won't show up on that real quick, but it will definitely show if there's an intracranial bleed. So if you got an intracranial bleed, you're not going to give them the TPA medicine. You're going to do something different. Okay, so let's suppose now that we have made the diagnosis that this patient has, history of severe hypertension. When they come to the emergency room, blood pressure's 210 over 160. Now, this is say it's pretty high, and your patient is becoming more and more obtunded. So what are you going to do? Okay, I'll go back to the young lady that asked the question to start with. So now we've made the diagnosis.
What would you do next?
Yeah, we've made the diagnosis that it's a hemorrhagic stroke.
Would you have to somehow drain the blood?
You're going to have to probably drain the blood, but you're not going to do it immediately. Okay, well, the first place you can't do it immediately in the emergency room. You're going to have to get an OR, you're going to have to get a neurosurgeon, you're going to have to do all those kinds of things. So the first thing you do is, because this evolves very quickly, is you're going to have to be supported. You're going to probably get ready. You're going to probably have to trach the patient. Probably going to go on ahead, and get ready to breathe for him. You probably might have to put him on a respirator. You're definitely going to have to start IV fluids. You're going to have to do INO carefully, because now that's going to become an issue. And most critical of all, you got to treat the blood pressure. Okay? Because if you don't treat the blood pressure, that clot's going to get bigger and bigger and bigger, and despite whatever you do, the patient's going to die. Okay, so you really want to aggressively try to get the blood pressure down. Now, if you get the blood pressure down and stabilize the patient, even if they have to be on a respirator, you can wait typically a day or two to go in And in fact, it's easier to remove the clot after the blood begins to lyse a little bit. You can go in and actually remove it. Yeah.
How can you end up like waiting that long, or waiting even through a CT scan if it's only like 3 minutes till the brain dies? Like if it doesn't get oxygen, like how does that relate?
So in the hemorrhagic stroke, the brain is still completely perfused. Okay, this is a stroke down in the basal ganglia. Okay, so the symptoms that you're getting from this stroke are actually what we call a mass-occupying lesion. So basically, this is causing pressure. It's making the brain shift, and so it's not. You don't have to worry. The brain's not. It's still being perfused. You don't have to worry about the 3-minute thing because it's still the important part of your brain's still getting blood.
But it could like, doesn't it really quickly put pressure on the brainstem, kind of like the one?
Yeah, if it presses on the brainstem, you quit breathing. But if you're on a respirator, it doesn't make any difference. You're going to see. That's what I'm saying. If you know that this is the case, get ready to put them on a respirator because you're going to maybe have to breathe them until you can go in and take the clot out. Right? Any other questions? So this is an area where biomedical engineers have had a very significant impact. Before CT, MRI, and advanced imaging technologies, it was all a crapshoot, as to what you do, and obviously, it was fraught with all kinds of mistakes and other problems. There are a lot of other things that you can do. If somebody's having a stroke, you can cool their body temperature. One of the other things that happens when you have a stroke is that area of dead tissue, it becomes inflamed, and because it's inflamed, it becomes edematous. It begins to swell. And the brain swelling then further compresses the watershed circulation. And when that happens, you get collateral damage. You basically get other parts of the brain that are still perfused that actually then begin to lose the circulation, the perfusion to that. So a lot of times, you have to, cool the patient. Obviously, there's some other things that we do too, like steroids, and you can give them osmotics to decrease the edema. So that's kind of what you need to know about stroke. Hemorrhagic and ischemic. You need to kind of know a little bit about how the circulation occurs here. So you need to know the difference between the middle, anterior, and posterior circulations and the kinds of symptoms that they produce. But
Whenever someone has a heat stroke, is that a hemorrhagic stroke?
that's what kind?
Heat stroke.
Heat stroke. Heat stroke isn't a stroke. Heat stroke is something different. Usually heat stroke, basically what happens there, you get really dehydrated and you get osmotic changes. I think we talked a little bit about that. Amy maybe talked to you about it. I think she gave you an example of somebody that got really dehydrated or overhydrated. It produces some other issues, but it's not a true stroke. Okay. So there's some other things too, just in terms of just kind of preventative medicine kinds of things that you can do to prevent a stroke. Obviously, one of the big things is control blood pressure. This is a huge risk factor, for stroke. So somebody that has history of hypertension, you want to treat them aggressively. For the ischemic kind of stroke, particularly the kind that's embolic, good heart health. And so good heart health includes, making sure that the lipid profiles are okay. So we do, tests where we get, good cholesterol, the HDLs and the bad cholesterols, the low LDLs. And so we can plot out somebody's risk factors for heart attack and stroke. And with that, you can, control blood pressure and typically we use the statin drugs. You hear about them on TV all the time, Crestor, Lipitor, all of those drugs that can change your risk profile. So we know actually that the propensity to develop these issues, the propensity for arterial sclerosis actually begins when you're a teenager. So you guys, really need to start thinking about what you can do now to change your risk profile when you're, 60, 70 years old. Particularly if you have family history. So how many of y'all have a family history of heart attack or stroke? And a significant number, okay? So, you know, you want to choose a lifestyle that's not stressful. Forget being me. And you want to exercise, and you know, occasionally you ought to, when you're going to go to Walgreens or CVS, check your blood pressure, because even at your age, you can get, you know, blood pressure issues. It's kind of important to address that. Okay. Any other questions about stroke? Okay. So let's kind of continue a little bit with the anatomy. And so there are certain features. Our brains, you know, as we, you know, when we're first born, they're exactly the same. But as we get older and things, you know, we have memories and things like that, they actually convolute differently. But there are some certain features that are absolutely the same, whether you're a man or a woman, irregardless of age. You know, basically you're going to have this kind of architecture. And so you're basically going to see, you know, this part of the brain which looks completely different. This is the cerebellum. Okay. You're going to have the temporal lobe. This is called the superior temporal gyrus here. Turns out that your primary auditory area is here. Okay. And so you're going to have vision here, and then motor and proprioception are here. Okay. And so everybody has pretty much that kind of same architecture. The frontal lobe is where you do your thinking, your cognitive thought, those kinds of things. So this is actually a sagittal section through the brain, and it's got some features that you need to memorize. And so I'm going to go over those features that are important to memorize real quickly here. There is a very, very big white matter tract that connects the right and the left hemisphere, which is called the corpus callosum. And so you have a genu, a trunk, and the splenium of the corpus callosum. That's a white matter tract that connects the right and left hemisphere. It's really interesting, but about 50 years ago, a very popular neurosurgical procedure was to take a knife and just cut the corpus callosum. And that was done for intractable epilepsy, for people that had uncontrolled seizures. And what happened is that, you know, these patients that got the corpus callosum section ended up with a right brain which could not understand what the left brain was doing. So we basically have a right brain, left brain disconnect, and it produces basically an inattention to everything on one side or the other. So some very interesting syndromes. Fortunately, that's not done much anymore. So right above the corpus callosum is a structure called the cingulate gyrus. That's this structure right here. This is actually very important in learning and memory. So this is a deep structure there. Right here we have the optic chiasm, and this is the hypothalamus, and this is the pituitary gland right here. Okay? And so right underneath that are two little bumps called the mammillary bodies. And the mammillary bodies are connected to the fornix, and the fornix then goes to the hippocampus. You can see that right here. Here is the mammillary body, connects to the fornix, and then goes to the hippocampus. So mammillary body connected to the fornix connected to the hippocampus. And this is actually the circuit that you use for memory. Okay? When you memorize all these structures, this part of your brain is extremely active. Now, inside this, we have the thalamus. The thalamus is the great relay nucleus of the brain. So all of your sensory information, including vision and hearing, goes through the thalamus. So just remember, thalamus, great relay nucleus of the brain. And then here's the uncus. Uncus is involved in some processing of olfactory sense. The uncus and the amygdala are very important in affect and in processing olfactory information. So that's right here. That's an important structure. You can see here some other things that are important. One is called the quadrigeminal plate. Here's the aqueduct of Sylvius through the peduncle, pons, and then the medulla here. So you need to kind of get that kind of burnt into memory there too. So those are just kind of some gross features that are very important. If we do a coronal section of the brain, you can kind of see that these are all three-dimensional. You have the section in different places. But we have the corpus callosum, which is the big white matter tract which connects the right and left brain. Yes, I'm sorry.
I was going to ask a question about the corpus callosum. Does that have anything to do with like ambidexterity and dexterity, like if you have like equal right and left hand abilities and everything?
Probably has something to do with it. I mean, it's probably related. It's real interesting, how you become ambidextrous. But yeah, it kind of helps to coordinate. Anyway, so you have the corpus callosum, which is connecting the right and left brain, which is right underneath the cingulate gyrus. And so that is a tract which goes from right to left. Now the big tract which goes from your brain down and down up is called the internal capsule. And so this kind of a V-shaped thing here, right here, of course you have it on both sides, is called the internal capsule. It's a very important landmark for the brain. So the internal capsule is carrying all of the proprioception, pain and temperature, all of the sensory information up to the brain. It's also sending all of the motor down from the brain to the nerve nuclei and to the spinal cord. So the internal capsule is up and down, corpus callosum is right and left. It's just a good way to kind of get a feel for what's going on here. Now, there are some other tricks that I'm going to show you here that will allow you to be able to look at a cross-section of the brain and be able to tell exactly where you are and to identify the structures of that section. Okay? So it's really important to understand that when you see the third ventricle, and here's the third ventricle right here, whenever you see that, you're going to also see the thalamus. So just associate third ventricle with thalamus. Okay? Where you don't see the thalamus and you see the internal capsule, you're going to probably see the caudate nucleus. That's this nucleus right here. Okay? Now, if you look also at the relative position to the internal capsule, every cross-section that you will see, the caudate nucleus and the thalamus are medial to the internal capsule. They're inside the internal capsule. The caudate nucleus, this nucleus right here, and the thalamus are always medial, okay, to the internal capsule. The lentiform nucleus, which is the globus pallidus and the putamen, are always lateral to the internal capsule. So these lentiform nuclei here are all to the outside. They're lateral to the internal capsule. So if you remember that, if you just remember that little simple trick, it will orient you when you look at cross-sections of the brain as to what structures you're looking at. Okay? Just some interesting little tricks there. So the thalamus is an incredibly important structure. As we start looking at the wiring diagram for the brain, we will go through these one by one, and you'll learn all of the 12 nuclei of the thalamus. Okay, the ones that I can tell you real quickly that we're not going to talk much about in this class are the lateral geniculate and the medial geniculate nuclei. The lateral geniculate is a relay nucleus for vision. Medial geniculate is a relay nucleus for hearing, for auditory sense. That said, you'll learn about that more in the second part of this class in the spring semester. But in this semester, we're going to be talking more about proprioception, pain and temperature, those kinds of things, which really kind of involve some of the other nuclei of the thalamus. So again, here we're looking at kind of the dorsal aspect of the brain and brain stem. And there are some very characteristic features here which pop out real quick. One is the pineal gland. Pineal gland is important in making melatonin. It's part of your system that regulates the night, daytime sleep cycle. It's kind of part of your clock. That plus some other nuclei in the hypothalamus regulate your kind of 24-hour cycles. And then these other structures right here, this is called the quadrigeminal plate, which is a pair of superior and inferior colliculi. The superior colliculi are nuclei for vision, visual motor, and the inferior colliculi are relay nucleus for auditory sense. So these are important. That's called the quadrigeminal plate, which are the superior and inferior colliculi. And so all of this that we're looking at here is the thalamus. There's another interesting structure here which is called the septum pellucidum. There are a number of syndromes where you're born without a septum pellucidum and have a constellation of other issues, mental issues, but we're not going to talk much about that in this class. And then here's the fornix. So this is the fornix is the structure that helps process memory, connects the mammillary body with the hippocampus. So you can see that there. And here's the third ventricle here. And then all the rest of that is pretty much that's the thalamus. Okay. So here's another kind of interesting picture. I like to start with this right here. So basically you have the cerebellum here. And the cerebellum, when you get a fresh brain, the cerebellum is kind of floppy and it's kind of connected very weakly to the brainstem. In fact, you just kind of pop it off like a nut out of a shell. But anyway, this is an important structure for motor. Here is that little structure we talked about before, the aqueduct of Sylvius that gets blocked, reaches internal hydrocephalus. Here is the quadrigeminal plate. That's the superior and inferior colliculi right there. This, from here to here, is called the mesencephalon. Okay. From here to here is called the pons. And this is the medulla. And together, the mesencephalon, the pons, and medulla make up the brainstem. You can actually see on this other diagram the pathways that connect the cerebellum. The cerebellum, again, is connected into the brainstem by virtue of a superior, middle, and inferior cerebellar peduncle. They're also called brachium conjunctiva, brachium pontis, and the restiform body. So you'll see that nomenclature in different books. Here's the quadrigeminal plate here. Here's the cerebral peduncle. The cerebral peduncle is the lower extension of the internal capsule, and that's actually the motor pathway, which is going down into the spinal cord. So I'm going to walk through. These are dissection plates, and so when we do brain dissection, and I'm going to do a virtual brain dissection for you, which are just pictures that I have taken when I've done actual live dissections for my graduate students. And so I'm just going to take you through, what you would see if we were doing a live, brain dissection. Okay, so we're going to start with sagittal